Okay, everyone, so I think we're going to get started. Thank you so much for bearing with us with the technical difficulties and joining us for today's Teach Educational Rounds. Here with us is Dr. Peter Selby, and he will be presenting an update on cannabis and mental health in an age of legalization. But before I hand it off to our presenter, I'm just going to go over a few housekeeping slides as per usual. So if you're interested in obtaining a letter of completion for this Teach Educational Rounds, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed in to view this webinar using your first and your last name so I can track your attendance, and you also complete the evaluation and post-learning assessment that will be emailed you today, and you will have 1 week to complete this. These webinars are being live tweeted on Twitter. You can follow us at PSQuitSmoking or use the hashtag TeachWebinar to post or read any questions. As well, please feel free to post these in the chat box. And here's a biography of our presenter, Dr. Peter Selby. He is the Chief of Primary Care, Deputy Physician in Chief Education, and Clinician Scientist at CAMH. He's a professor at the University of Toronto, and he is also the Executive Director and creator of the TEACH Project. You can read more about him in these slides. Here are his disclosures, as well as our disclosures. And this is just a friendly reminder that the TEACH curriculum slides are primarily based on evidence-based guidelines from the following sources. And these materials, as well as the verbal presentation and any discussions, set out only general principles, and they do not replace the need for individualized clinical assessment or treatment plans by healthcare providers. And before I hand it off to our presenter, I'm just going to go over a few polling questions just to gauge who is joining us here today. So in a minute, using your computer, could you please indicate which of the following you work for? And if your organization isn't here, you can type it in the chat box. So everyone should see this poll now. So it looks like we have some family health teams, some public health units here, hospitals. Awesome. So now can you please indicate what your current discipline is? And you might just have to scroll down to see all the options. So some registered nurses, a lot of health promoters and educators, addiction counselors, awesome. And for the last poll, can you please indicate what region your organization serves? So Toronto and Greater Toronto area, Eastern area. We have some from Ontario-wide, outside of the province. Awesome. Okay. So now I'm going to hand it off to our presenter, Dr. Peter Selby. Thanks, everyone, and enjoy.
Thank you. Thanks, Stephanie. Welcome, everybody. Good to have so many of you joining us today. We have 294 people who signed in, and I'm sure there are places where there are groups who've joined in, so it's really obviously a topical issue, and the learning objectives are in front of your screen. One of the things that I want to make sure is that you can hear me. So if you can't, yeah, I got it. So I'm going to hold my the phone much closer to my mouth. And one of the things is, hopefully this is better, but one of the things is that as we're going along, feel free to type into the chat box. We are monitoring that. Should there be anything that is problematic, or if you have any questions. So what we want to do is, I'm going to run through a whole bunch of slides, but hopefully this is helpful to you, and then I'll have time for discussion. So what we want to do is identified the risks and benefits of cannabis use in patients with mental illness and addiction, explains the risks and benefits of cannabis use in patients with mental illness and addiction, and then discuss some of the treatment approaches to cannabis use in clinical populations. So very quickly, I'm going to run through a case, give you a brief overview of cannabis, why legalize, the psychological effects of cannabis, and how to intervene with patients, what are some of the evidence to date, which is not a whole lot, but what we could do with respect to medications and psychosocial interventions, and then just summarize. Okay, so let's take a look at a case. This is not an uncommon situation, and some of you can type in if you've seen this kind of situation. It's a young person who's had a long history of using cannabis that has now come to the emergency room for their third visit. They've been coming in with explosive sudden onsets of vomiting, abdominal pain, and cramping, no diarrhea. They've been dehydrated but not hemodynamically unstable. They've needed IV fluids both visits. And they report that, you know, if they ask the onset, they tell you they've been smoking cannabis for maybe 10 plus years. They smoke daily. They've been smoking 3 to 5 joints a day. And notice that in the mornings they've been noticing that they've been getting nauseous for a while now, and suddenly have these bouts of emesis, and they've been trying to smoke more cannabis to suppress that. But the more they smoke, the more they vomit. But I've noticed that after a hot shower, they get better temporarily, and then they can take some food in, but again, then they smoke up cannabis and they vomit again, and they get into this cyclical thing. Obviously, they get worked up. Nothing is found. They're not pregnant. And what's going on? And again, this is something known as the CHS, or cannabinoid hyperemesis syndrome, which is exactly what Tanya typed in there, is that is what you see. And again, you can divide that into some of the complications that you will see in people who start using cannabis in high doses and frequently. So what is cannabis? Obviously, cannabis is a plant, and there are parts of the plant from which over 100 different cannabis alkaloids or chemicals are found. There's both a flowering plant, a male and a female, and the female has a higher concentration of several of these alkaloids. And we talk about the cannabinoids and terpenoids, and the two ones that are important for the psychoactive component, obviously, is the tetrahydrocannabinol, which is THC, and that is what is a psychoactive constituent, and it attaches to a part of the brain, what are known as cannabinoid receptors. We have natural endogenous cannabinoids called anandamide, and that attaches it, and it has to do with a lot of functions, and I'll come to it in a minute. But this exogenous or external cannabinoid is found in the THC plant. And cannabidiol is a non-psychoactive compound, and might be one of the reasons for why you get this hyperemesis syndrome. There's that CBD, and there's something also called CBG, or cannabis glycerol, I think, which is what might be accounting for this vomiting. So it is essentially, depending on how much and the types, you get different concentrations of THC to cannabidiol. So often it's a 1-to-1 is where you often see that, but you may get different variations of more THC, less cannabidiol, or more cannabidiol, less THC. The dried flowering buds are often known as marijuana, and it's a Spanish term, and then the resin is where you get the hash and the hash oil from. So first medical marijuana was used in 12,000 BC, and you can see in the slide that it is spread, it took a while to spread across the world, coming into North America around 1910 or 1920s, and not a whole lot of recreational use happening. But because of this invasion from the South and the prohibitionist movement, they had to make people get afraid of cannabis, and therefore they called it marijuana, because you can see how some of this warning signs is about how basically it was a way, it had a lot of racist overtones, and it was a way to get the population at the time to be afraid of people from the South, and especially from Mexico, and which is why they stopped calling it cannabis and adopted this exotic name of marijuana. And you can see how they make people afraid of it: murder, insanity, death, and which is why we are now facing some of the problems that we have. Now, when you take a look at the toxicity of marijuana, if you look at this slide, which looks at the dependence potential on the y-axis, and you look at the active dose and lethal dose, you can see cannabis is moderately to, has low to moderate dependence potential, but lethality is very, very low. So this is one of the things that often where you'll see people using it, and there isn't really an overdose risk from that perspective. It has medical complications, but killing people off is not a problem. And so we went into an age of prohibition at the same time as alcohol prohibition came in, and the war on drugs started. But during alcohol, there was a loophole, and that was called the medical alcohol. Who knew? Similarly to cannabis, you could go to a doctor and get a prescription and then fill it at the local pharmacy for various types of alcohol. Whether in this one it was port wine, but people could get gin or anything that was helpful. And for this indication, prescribed was something called influenza. So it's very interesting that we had medical alcohol. And why is that important? Because once prohibition went away, medical alcohol also disappeared. And it will be interesting to see if history will repeat itself and we'll see a disappearance of medical marijuana and simply have a recreational cannabis culture that comes through. This timeline tells us where we've started, and really this is a new phenomenon in the sense that till the 1930s you didn't have much recreational use, and then you started seeing 25 convictions for cannabis in Canada, and then into the 60s and 70s, now you start seeing a lot of it. And as far back as the 1970s, it says that Canada's prohibition laws created little respect for law enforcement, congestion of the judicial system, and strengthened organized crime. And so we really see this sort of the Ledane Commission saying, look, you really need to think about how you regulate cannabis and whether it really needs to be under the same regulation as other more dangerous substances. The Supreme Court sought to prohibit the possession and production of cannabis, but then medical cannabis got legalized in 2011, and now 2018 we're going to have the Cannabis Act, which will legalize and regulate recreational cannabis by October 17th, and the policy focus on health impacts and public safety. So what is the use of, how is cannabis used currently based on surveys and other data in the age prior to legalization in Canada? We've seen that it's the most widely used illicit drugs. It doesn't come anywhere close to the legal drugs like cannabis, but like alcohol and tobacco, but out of all the illicit drugs, it's 10 times more common. But you also see that at the same time, as I said, you can see alcohol consumption is 76% of the population and 15% of smoking prevalence, and roughly 10% for cannabis. So why legalize is because our current war on drugs has not worked. It's simply caused more problems. You'll end up with 60,000 Canadians being arrested per year. 3% of all arrests are because of cannabis possession and use. And what the downside to that is, because cannabis use is concentrated in the young people, the future of our country, you'll end up with about 500,000 Canadians who will carry a criminal record, which means it has implications for where they can work, where they can travel, and can substantially get them much more involved with the criminal element in society. And it costs us a lot, close to $1.2 billion. So I said, who uses cannabis? I mean, we've seen from 2011 to 2015, a slightly increase in the prevalence of cannabis use reported. Now, does this mean more people are using or just people are much more honest? It's hard to tell. But you did see this low point coming down to 9.1% and going up to 12.3%, which is what we had in about 2004. So it's not clear why this is happening. It could be that people believe it's safer and they are much more willing to talk about it. But we have at least 12% of Canadians 15 years or older who've used it in the last year, more men than women. And again, it's concentrated. The highest proportions are in the 20 to 29-year age group. So young adults are the ones who are using it, but just as you get older, there may be less reported use, but you are beginning to see older people using it, especially people who grew up, who are baby boomers or now, who either never stopped or continue to use it as they get into their silver years. Generally, obviously, BC is the highest prevalence of cannabis use, and which is very interesting because it's the lowest prevalence of tobacco use in the country. We also have, followed by Ontario and 15.5% in Nova Scotia, which pardon me, is the highest, and Saskatchewan is the lowest. Now, when we look at the associations between mental illness and cannabis use, basically this slide says that the more cannabis use there is, with less weekly and at least weekly, you will see the odds of being diagnosed with or having a mental illness going up. We cannot say causation because it could be bidirectional, but you can see this by the slide that you have this connection between cannabis use and any mental illnesses, and back then we had DSM-4, so it had Axis 1 and Axis 2 disorders, and you can see it is highly associated with the Axis 1 and Axis 2 disorders, as well as other substance use disorders. And in fact, in many cases, many substance use programs ignore the use of cannabis, especially opioid use, like methadone programs just tend to ignore the use of cannabis. But what does cannabis do to the body? So our brain, as I mentioned earlier, have these cannabinoid receptors, and there are two types, CB1 and CB2. CB1 receptors are where THC acts, and it is where the brain, where an anandamide acts, and it is the place which is associated with why we get some of the psychic effects of cannabis. And most of its highest concentration is in the brain, but the brain also has these CB2 receptors. But you'll see where it's colored blue, there are also CB receptors, for example, in the lungs and the gut. And it is possible that this is why we have some of those effects of the hyperemesis syndrome. And CB2 receptors are primarily, in the gray here, are primarily in the immune system and modulate the immune system. So these are very common modulators in the body, and they're ubiquitous and can get stimulated or activated by THC. And one thing I'll say about THC or cannabinoids in general, that our body fat stores them, and that has implications because if you're stored in your fat cells and you're starved, you can get some release of cannabis, and that can have impacts of what we call reintoxication that happens later. So cannabis is not like a drug that comes into your system and leaves. It's not like alcohol. It actually gets stored in the body, and people who use daily or chronically are actually creating a body fat store of cannabis in their bodies. So what are some of the effects? Obviously, immediately you're going to get some things that affect the blood vessels, and therefore the eyes look short. It could be the smoke that irritates it, so people look a little, you don't have much changes in the pupillary size, but you do get an increase in heart rate and pulse, and then you get a general decrease in motor activity, and you get increased hunger. And often you will see long-term effects that then become, over time, respiratory infections because of the way people use it and no filter and take deep inhalations. Obviously, we can see these long-term effects on physiological functions like heart rate and pulse. And then there is mixed evidence to suggest that there may be some studies show an increased risk of lung cancer, others don't, but an association with some of the effects of smoking, which is like heart disease, strokes, and TIAs. Unfortunately, it's hard to separate these out from tobacco because co-use is more common than exclusive use of cannabis. Obviously, we are most concerned about the brain because the anandamide and the cannabinoid receptor system is most active in right from prenatal age group till much older. And the brain develops, as we know, to the age of 21. And we think the brain is more vulnerable to THC during this time. Of interest is actually prenatal exposure or exposure during pregnancy. You may not see those effects on the fetus. You may not see the effects on the baby up until 5, 6 years of age or even later. And so although the effects of smoked cannabis in pregnancy is less than that of tobacco in pregnancy, there are some effects that clearly people need to watch for. And the reason why we say that is that as anti-emetic medications in pregnancy are getting a bad rap, more and more people are beginning to trust cannabis as a safe herbal alternative, and clearly aren't paying attention to some of the long-term consequences. But the earlier that a young person starts cannabis use, the greater the impact is going to be on their brain. And you can see this in a dose-response relationship in terms of how you could see a decline in IQ over time in people who become chronic users. You can get reduced alertness, self-conscious awareness, memory and learning problems, reduced sort of inhibitory control, so they get much more disinhibited, and a change to those receptors, the CB1 and CB2 receptors in the body. And again, obviously associated with impairing functioning, and in young people that means dropping out of school early, and therefore setting them on a trajectory that essentially can get them out of the economy of the country. This is a summary slide, but basically says that because cannabis CB2 receptors are in every part of our brain of what we think, how we learn, how we feel, how we respond, you're going to see alterations in all these systems in our brains. So obviously we get behavioral effects of acute intoxication, so people end up getting relaxed, get less motivated, but you might have and will have impacts on coordination and signal detection. Obviously, so that's the behavior that you see. And sometimes it's hard to tell if people are under the influence. Sometimes they're giggly and laughing, but sometimes chronic users, you may not be able to tell. The cognitive effects can be subtle. There's impaired short-term memory, cognitive functioning, perception of time. Time seems to move slowly. Attention may be problematic, or they may be having difficulty with retentiveness. And why is this important nowadays is because as the population is graying and people think they don't look like people who use cannabis, but guess what? They may have grown up with cannabis. We've had cases where people seem appearingly high functioning, coming in with mental illnesses, and when you screen for it, they've been smoking cannabis and complaining of some of these impacts, especially as they get older. So even geriatric populations need to be screened for the use of cannabis. And of course, we can see the mood changes that are much more evident, and often the reason why people will use cannabis because in social situations as well, because it is a pro-social drug in that way. The additional effects of cannabis, of course, it can have a psychological effects like making people paranoid, etc., and worried. But the other things is that they're 3 to 7 times more likely to be responsible for a motor vehicle accident. So yes, there's lots of joking that goes on. So well, you won't be driving fast if you're high on cannabis, but problem is that your reaction times and the way you respond to driving situations is varied, and a lot of people land up mixing alcohol and cannabis, and they get this double high, which then impairs their ability to drive. Or they've taken it in an oral form and felt nothing, but then a few hours later they've gotten behind the wheel and now it's kicking in. So that is a potential problem with cannabis, whether you're smoking it or taking it orally, that the psychomotor impairment in performance is problematic, and how long that lasts is problematic. And again, in the workplace, we've got to, as it gets legalized, you're going to have to worry about that, because you certainly don't want your surgeon to have been smoking up cannabis the night before and then starting up the OR in the morning, because those effects could persist. And especially if they're regular users, they have a body fat store of that, and you don't want them to get re-intoxicated as they are operating on somebody. And so that implies for a lot of people in safety-sensitive jobs, even if you're going to use it recreationally, you're going to have a response to this. It isn't like alcohol that, you get rid of one standard drink an hour. This is an unknown phenomenon that we will have to see as it gets legalized. There is a possible role as a gateway drug. In fact, nowadays you hear more young people saying they started with cannabis first before they switched to tobacco or added tobacco. And then we talked about the increased risk for ED visits from several reasons. One, psychosis, and two is this cannabis hyperemesis syndrome. So what is the evidence for all of this? For medical cannabis, there's a lot of anecdotal evidence, and I have patients who said, look, and we've had healthcare professionals who've taken it on. We have vets who are giving it out for pain, and they will swear by it. And I have no way to discount their personal experience other than to look at the science to say, okay, so what is the medical studies that show that this works? So for nausea and vomiting due to chemotherapy, three trials, 102 people, use of dronabinol, which is the synthetic THC, and Nabiximols, 3.2 greater odds of complete remission of nausea and vomiting compared to patients treated with placebo. Now, this seems paradoxical. Why would people get hyperemesis and also this works for nausea and vomiting? Here's why. What happens with THC is that it slows the gastric emptying. So all the cannabinoids slow the emptying of the stomach. So you would expect people to vomit. But centrally in the brain, it suppresses, the cannabinoid receptors suppress the vomiting center. Enter CBD and CBG, and it seems to flip it, and then people land up vomiting. So that seems to be the theory as to why you get this hyperemesis syndrome in these individuals. Coming back to the slide, chronic pain, minimum 30% reduction, 8 trials with over 1,300 people. The odds ratio seemed to cross 1, so that means it could be making no difference, or we found this result by chance alone, or the issue is that when you smoke THC and Nabiximols, you don't get a 30% reduction in chronic pain compared to patients treated with placebo. So there is, if you pool all these trials, there doesn't appear to be, it could be by chance alone that people get better. In neuropathic pain, again, no reduction, and cancer pain, no reduction. So the best evidence is for chemotherapy-induced nausea and vomiting. So this is just to show you, as cannabis use will go up, you'll get a significant increase of about 100% in the number of ED visits, and you can see this from 2004 to 2011. This is looking at U.S. data, and what happens is you'll start seeing it in combination with other drugs, and so this does become problematic for healthcare utilization, and as legalization happens, and people think that legalization means no rules, which means use it anywhere as much as you can under all circumstances. this is where you're going to see some problems. And here's the thing with cannabis. Often people don't get the hit or the high instantly as soon as they smoke it or eat it. And so continue to consume and don't have a mechanism to stop themselves like you have with alcohol and other drugs. So it'll be, let's see what happens as this gets out and becomes legal. And it speaks to the fact that people need to be educated about how to use safely without getting themselves into trouble. A big concern, obviously, is that, which was found in the Dunedin study, is that people who had a certain variation in this 22q11 SNP, RS4680, which means a gene variant on the 22nd chromosome on the Q region at 11, that's where there's a variation, and this variation accounts for how the body breaks down certain neurotransmitters. It found that this variation was associated with increased risk of having psychotic symptoms. So it was about 1.4 times higher when using cannabis. So this is where some of that idea, unfortunately, or fortunately, the study has not been able to be replicated in other places. They haven't been found. This is only in this one study where they were able to find it. So when you ask patients with psychosis, why would you want to take a drug that, you're already having difficulties with perceiving reality and perceptions with things? What benefit would you experience from taking cannabis? Often what you'll hear from patients is that it enhances their mood. They often on medications, they're finding flattening of their mood, and they find this cannabis gives them a break. It also is social because often they're young people. They're often being isolated because of their mental illness. Cannabis becomes a connector with their buddies and can help them avoid social isolation. Some of them say it's a self-medication, and you're asking, well, but you may get more paranoid and you may get more psychotic with it. And they say, well, often it is to relax, and it can help me sort of not pay too much attention to my hallucinations and suspiciousness. So this is what patients will report, and can explain why people continue to use it even after they've had a psychotic break in an episode. The risk is that you get an increase in psychotic symptoms, both the positive and negative symptoms and general symptoms, and the risk of, because of the dissonant effects of it, potential increase in violence and convictions for nonviolent offenses. So it's a mixed bag for people with mental illness, especially with psychosis. And clearly, I think where we land up is saying, look, we understand that this may help these short-term, immediate, sort of intoxicating effects or pleasurable effects, but the long-term risks are greater to your mental health when you have a psychotic illness. Because really, when people, this is basically from a study done by Van der Meer, which shows that those who discontinue cannabis will show improvement in both their positive and negative symptoms compared to persistent cannabis users. So, and it's in a dose-response system. So this is something called the PANIS, and which looks at the scores of positive symptoms by cannabis group and negative symptoms offered by cannabis group, and you can see that you get a general improvement the less people use, and best with if they quit altogether. So again, when they quit doesn't matter, but a 3-year follow-up study suggested that when they quit, cannabis doesn't matter, but if they should quit, because they do get better if they do quit it. And what means is that we have to work with people with a history of psychosis to get them motivated to stop completely and keep going until they do, because they will have an improvement, because the impact of cannabis on the severity of symptoms is reversible. So the take-home message is that if you have a young person or any person who's had psychosis, one, really help them, motivate them to quit cannabis and keep going till they do. And it may take some time. This is just showing you that it doesn't matter when they quit. There's no difference, but there is an improvement in this, and clearly it should be done. When you look at the study about the dose-response relationship with psychosis in 60 individuals, you can see that roughly the take-home message is that more severe use is associated with more severe symptoms, and reduced use has the greatest improvement in symptoms for every symptom scale. So more than one study suggesting, look, if you have psychosis or schizophrenia, use of cannabis, yes, you may not be ready, but use ways to help them come off it as soon as possible. And if they can't come off, the less they use, the better. And here's another one just showing you that relationship of severe cannabis users have an odds ratio of 3.9 and varies from 2.84 to 5.34 for people of high users of cannabis, looking at that dose-response relationship and even showing that any cannabis use is not good for mental health, especially psychosis. What about mania? Again, with mania as well, 6 studies, 14,000 patients. You can see the odds ratio of experiencing manic symptoms is on average 2.97, but varies from 1.8 to 4.9 times. So the odds ratios are really high compared to non-users. And so people who have bipolar disorder should be encouraged also not to use. Interestingly, lots of people will say that they use cannabis for their anxiety, but you can see this association between anxiety and cannabis use. 15 studies, the odds of anxiety is 1.25 times higher when using cannabis. So they are anxiogenic as well as anxiolytic, which means anxiety causing as well as anxiety reducing effects of cannabis. And sometimes you will have stories where people said, okay, I started using cannabis to manage my epilepsy, and I feel good about it, and I'm managing, but I'm getting way more anxious. So that is also a possibility, and that this association between anxiety and cannabis use disorders. Anxiety, depression, and cannabis use, again, you can see that it's 1.68 times higher when using cannabis, and these are significant findings. Interestingly enough, when you have baseline cannabis use, 5 studies in follow-up, because often people say, is it the chicken or the egg? With cannabis use, there are 5 studies that look at the relationship of anxiety in follow-up, and you can see that there is an increase in anxiety symptoms in follow-up in people who start using cannabis and did not have anxiety symptoms at baseline. And in the lower one, where there's anxiety symptoms at baseline, there's one study, and there's cannabis use later, that you don't really see much reduction, although there's a huge belief that smoking will help reduce anxiety. And you hear this with people who drink alcohol as well. Well, I drink, I'm less anxious, but guess what? Over time, you're more anxious. So really, that idea that people are using cannabis as a way to manage anxiety is more anecdotal as opposed to true effects of that. When you take a look at the National Longitudinal Alcohol Epidemiologic Survey, that individuals who meet criteria for DSM-4 major depression in the last 12 months have a 6.4 times the odds of meeting criteria for DSM-4 cannabis abuse and dependency. Now we don't have abuse and dependence, but and it's about 6% versus 1%. So this association is something of concern, and so we have to think about what it is. It could be that with depression, cannabis may impact brain chemicals like serotonin. In fact, cannabidiol has an impact on the serotonergic system, and it in some situations might help. But with the combination and the mix with THC and some of the other compounds, it's unknown what that impact is going to be. But we do know there may be impact on serotonin, dopamine, other neurotransmitters, regulating our emotional experience. So that may be one reason. But it could also be that when people are using cannabis, the external environment and those circumstances might be exacerbated. The person may withdraw from society, and increase the likelihood of depression. And there may be some unknown other factors that both cause the person to use cannabis as well as to cause them to have depression, and mediates that relationship. Now, one of the problems when studying cannabis and trying to make associations with causation, there are a lot of confounders. Most cannabis users tend to be male, young people who have less education and have an earlier age of onset of psychosis, also using other substances, having more symptom scores on most mental health issues, and most of the studies don't control for their concurrent use of tobacco, which we know also has psychoactive properties. And so how much of it is cannabis alone, how much of it is cannabis mixed with tobacco, and the type of cannabis and the frequency of cannabis and the other substances used in somebody who might have a vulnerability for a whole host of problems because of biological and social and economic issues. So having said that, the evidence is, as we look at cannabis getting legalized, for the most part, we hope people will come out of it without having any immediate or long-term harm. But for those who do, will become our patients. There's some estimate to suggest post-legalization, we should see overall about 1 million people who will land up with some sort of cannabis use disorder. And so this means they're using cannabis daily, it's impairing their functioning, it's impairing their relationships, and they're having consequences, and they're unable to stop despite having a desire to stop. And so what are the interventions available? To date, overall, the studies have been pretty poor, but there are a few that I'll go over that will give us some indications of what we might do. There are interventions that say you can use sort of THC preparations or cannabidiol preparations. Could we use SSRIs or antidepressants? Could we use anticonvulsants or mood stabilizers? So that's the pharmaceutical sort of approach to it. And then what we always go to, which has a behavioral component or has an addictive component, are two things: motivational intervention to get people ready and motivated, and then CBT as a way to get people to be able to stop completely. So let's take a look at the medications. Basically, preparations that contain THC versus placebo in about 207 patients, 2 studies. You can see preparations that contain THC increase the likelihood of completing treatment by 29% compared to placebo. So whatever it does, it keeps people in the treatment program, if nothing else. SSRIs do not increase. Mixed action antidepressants do not increase, and neither do anticonvulsants. So people who are giving people all these other medications as a way to treat their cannabis use disorder, it's not going to make a difference. If somebody meets criteria for depression, absolutely treat them. If they meet for mood instability or they have bipolar disorder, treat those with those drugs, but don't expect those drugs are going to stop the cannabis use. It might be that treatment of the depression and the bipolar disorder might help them be less likely to want to have substances, but more often than not, we've seen people often have a concurrent disorder, which means they're both they're two disorders affecting each other, but both need treatment. With respect to abstinence, preparations containing THC versus placebo, it doesn't increase abstinence rates compared to placebo. It could be that the studies are relatively small, only 156 patients in one study, and SSRIs do not affect it. Again, small study. The antidepressants don't, other antidepressants don't do it, and neither does the anticonvulsant. So none of the medications that have been tried to date have any evidence for abstinence. Of course, we have fixed or self-titrated doses, and these were done at CAMH. First author Trigo, lead scientist on that is Dr. LaFall. I was part of the study. But again, you can see how hard it was to get people into this. So there's something called Sativex, which is 1 part THC, 1 part cannabis, and it's a mouth spray. And we did it in an 8-week double-blind placebo-controlled trial, 1 week each, where they got self-titrated placebo, then they got fixed-dose placebo, then they got self-titrated Sativex, or they got fixed dose up to 108 milligrams of it, and they were given it in different ways, and then of course they had a washout period in between, and they were randomized and counterbalanced, so not everybody got it in the same pattern, so that you couldn't, people couldn't get unblinded. And so we screened 54, 16 were eligible, only 9 completed, and in part this was because there's a lot of work to do these kinds of trials. But interestingly, 7 out of the 9 participants remained abstinent during treatment, both with the fixed and the self-titrated amount. And it did not make any difference the number of times. So although we got people to remain abstinent during treatment, the number of times they relapsed and the total amount of cannabis consumed did not seem to differ between the two. It was well tolerated during and reduced their withdrawal quite substantially when they were abstinent, but it did not affect the craving, speaking that there's more to be done beyond that early stage of getting people out of withdrawal. So it seems to be doing that, but what about the next stage? And therefore, we need to study as to whether it can help in relapse prevention as opposed to simply getting people out of withdrawal. So this comes to where we go to is the psychosocial interventions, and here's the ones which have been looked at on study with 134 people. Individuals receiving CBT used cannabis on 11 fewer days in the last month compared with the inactive control. So yes, it can, it has a big effect, but it only has in terms of 11 fewer days. The next one, which is motivational enhancement, 4 fewer days in the last month. And if you combine the two, 7 fewer days. So it almost appears that motivation interviewing sort of takes away the thunder from CBT. And what this means is that motivation interviewing, as we know from that literature, it should be reserved for people who are ambivalent, not people who are ready to take action, because you may actually make them less ready through your intervention. So motivation interviewing can be harmful for people who are absolutely ready, maybe a good idea for people who are sort of ambivalent, and CBT for sure could be used for those who are ready, but look at those data. It's an issue of getting 11 fewer days, so it depends on what you're willing to put in. Obviously, from a harm reduction perspective, people use or report using fewer joints per day compared to the inactive control, similarly with motivation interviewing, and you can see again in this group, it doesn't seem to affect that. Motivation interviewing doesn't have that kind of interaction with CBT, but again, that's why, because people are probably not as ready as those who are ready to quit. So in a way, motivation interviewing and CBT should be used for people who are sort of ambivalent and CBT alone for those who are absolutely ready. When you take a look at point prevalence abstinence, so people are not using how we've done in smoking cessation for a certain period of time, not using, those receiving CBT increased abstinence rates by 381% compared to inactive control. So you can see that, and motivation interviewing doesn't do that. And again, it appears to dilute the effects of CBT. So again, goes to that. If you have somebody who is motivated and is committing to, wants to be abstinent, then use CBT because it'll help them not only reduce their days, but also reduce their chances of being abstinent. So again, the Nabiximols, again, another study that we did, we looked, this is a double-blind randomized controlled trial, as needed. So they got the Nabiximols, which is the Sativex, and they could use as much as they wanted. The problem is that they'd come daily, pick it up to go. We had 68 screened, 27 eventually completed the treatment. And Nabiximols combined with motivation interviewing and CBT was well tolerated and was associated with reduction in cannabis. So, but we didn't see any increase in cravings or withdrawal, but it didn't reduce them either. It didn't reduce cravings. It helped withdrawal, but didn't reduce cravings as much. And people were using up to 20 sprays per day. But we need to look at it better. Probably people need a higher dose, and need to, part of the study is problematic because you have to come every day. When you buy 30 grams of cannabis, you don't have to go to your dealer every day. So we've got to figure out how to make it easier to take treatment, but this was one of the first studies looking at this. So coming to the end of it, so if you take a look at all the evidence and you put it all in, and what's the most pragmatic and practical way to go forward, you can have lower risk guidelines. Now, there are no zero risk guidelines. Any psychoactive substance, doesn't matter what you're using, has some inherent risk. And the risk is from its use, and whether or not you're addicted. Any kind of intoxication or pharmacological effect can cause you harm for any drug. And one of the consequences of long-term use is obviously some of the long-term pharmacological effects and physiological effects, one of which is getting addicted. So to lower the risk, here are some sort of pragmatic ways based on the evidence that can help us reduce societal risk. One is reduce and delay use till adulthood. And people will say, can you delay it till 25? The problem is that getting people to delay it is going to take a lot of work and education to get them to do that because the highest prevalence, as I showed you earlier, is in young adults. Avoid frequent or near daily use, so really making it much more of a social activity as an occasional activity as opposed to a daily routine or a habit, or which will then become, or habitual use, which then becomes addictive. Try to move away from smoking cannabis to less harmful, either smokeless delivery systems such as vaporizers, and you'll notice that oral products are not there primarily because with oral products there's risks as well because of the onset may be variable and the potency may be variable. And so it's not as, so yes, you may not get exposed to smoke, but you may get exposed to higher doses or longer effects of THC that may or may not be safe for the individual. As I mentioned earlier, if they get behind the wheel of a car, they could be having this body high and can cause themselves quite a lot of harm. Try to use less potent products. The potency of cannabis right now in THC is about 30-35%. Back in the 70s, it was 6 to 7%. So you need to make sure that people are using a dilute form. And this is no different with what happened when alcohol got legalized. When anything is in less supply, people end up drinking the more concentrated form, which is the liquors that we have nowadays. And when it is in higher supply, people move to the wines and the fermented types, so a much more dilute form of alcohol. And again, we need to think about how to get people to use much more dilute forms of these drugs so that they're not finding themselves in harm's way. Avoiding driving at least 3 to 4 hours, if not longer. And I think the safest thing is if you've used, don't drive, and don't drive for up to at least a day, I would say, because we don't know how you're going to get affected by this. And of course, don't mix it with alcohol. If you are at higher risk, so personal or family history of psychosis, cardiovascular problems, pregnant women, ideally the recommendation is to abstain altogether. And so this sounds very familiar, like the low-risk drinking guidelines. This is with the low-risk guidelines that have come in. They've been endorsed by the Canadian Public Health Association, CAMH, and other groups. So let's summarize. As legalization happens, we don't expect the use to get any more common. You might have different people. Initially, you might have a bit of a surge where people who are curious will try it and then decide it's not for them. There may be some more people who will use it. But in other jurisdictions, you're not seeing greater prevalence. What you do see is potentially some harms depending on how it gets regulated. So kids getting it into getting intoxicated or getting poisonings from it, adults using in ways that they're not, they've never tried before, they're not comfortable with, and then they get into a problem, they get too high. So they may have a cannabis party, for example, and these elderly people are now, passing out, and this has happened in places where they've tried these things. People might say so they may want to get, if they're in places where there's drug testing, they may try to use, unfortunately, the more dangerous forms of the synthetic cannabinoids called spice, which are very dangerous and toxic, which should never be used, but some people do try to use them. So cannabis use is common in Canada. With legalization, we would make sure if we have good regulations that the harms from cannabis are actually minimized, and the social harm should come down tremendously in the sense we should not be filling up our jails with people, and people should not be getting criminal records. But we got to make sure that people don't now compensate by getting many more medical issues like the hyperemesis issues, visits to EDs, psychosis, and addictions to cannabis. There may be some benefits to cannabis as a plant, but we need to study it better and give it to people in ways that they don't have to take it in a dangerous route of administration like smoking. And we need to recognize that cannabis use has a significant association with mental illnesses, and we need to be careful that we don't simply buy into the anecdotal evidence that that cannabis is the treatment for people's mental illnesses in the absence of evidence. The good thing is that if people are addicted to cannabis, any symptoms they have can be reversed often by complete abstinence. And especially in the cannabis hyperemesis, it is really important to educate them when they're in the hospital and they're leaving the hospital that, look, okay, now you're not vomiting. Do not go back and use cannabis as a way to prevent yourself vomiting because it will make you vomit more. And often people go through that a few times. So they need to be educated that abstinence is a way to prevent those symptoms from coming back and why we recommend that. And of course, psychosocial interventions are going to be the foundation of treatment of cannabis use disorders. We need to do more work on treatments for it, and we've started some of that with the Nabiximols, but there may be other treatments that we need to find that can help do that. There's some work going on looking at variations in an enzyme that metabolizes cannabis called F-A-A-H, that metabolizes THC in the brain, and can that be modified in some way so that you can create treatments that essentially make cannabis less addictive. Here are some of the resources we've used, and we can open it up from questions, and I'll go to some of the questions that people have been typing in, and I'm going to try to read these. Okay, CBD oil, gel caps, can they cause nausea and vomiting, or is it just when smoked? That's a great question. We have no idea whether this is only when smoked. The people who come in typically tend to be people who are smoking cannabis, and for a long period of time they've had the prodromal where they've been developing this nausea, and then they flip over. And so it's not clear whether CBD alone is thought to be relatively innocuous psychoactively, in a psychoactive perspective, maybe accounting for some of its therapeutic benefits. And again, a lot of studies just got approved in the U.S., and I think you're going to see a lot more studies coming out about it. But whether CBD alone can cause, is seen in the real world with this because of the potency of CBD not being that high, I have not heard about any cases where it's just CBD oil or gel caps where people are finding this. But CBD itself is something that slows the gastric emptying and is associated with peripherally could cause nausea and vomiting. So technically it's possible, but not been seen. What are the indications for CBD prescriptions? Yes, nausea and vomiting is not one of them. CBD is typically given for people with epilepsy, anxiety, pain, a whole bunch of things. And I think there needs to be studies to look into it. And Monica asked about studies. Usually there have been smoked cannabis, and oral cannabis is, again, something that has to be, it depends on how that oil was taken out of the plant, what the potency of the THC in that is, what process was used, how much of it was added, what concentration was used. So again, there's a lot of variabilities in, but as you're seeing many of these medical cannabis companies come on, they are claiming that they're having, fixed concentrations, and the bottles will talk about the concentration of CBD on them and THC and what the ratio is as well. And Kelly, I'm not sure I understand your question. Does the diagnosis prompting a medical cannabis prescription dictate the delivery method of the cannabis? I don't know for sure, but I think if you're saying whether people can get this over in the mail, yes, you can with this. And Karen asked the question, do I mean psychosis resulting from use or pre-existing psychosis, and are they using to help with symptoms? So, this is a great question. We don't know whether people have prodromal symptoms of psychosis, at high risk of psychosis, and as a way to manage, they're starting to smoke cannabis, and then the cannabis is sort of now flipping the switch and making them more psychotic, and then they come to our attention. Or they were just not at risk for psychosis if they had never used. They don't have any symptoms, prodromal symptoms, but they're just using it with their buddies and socializing, and then suddenly find the toxic effect has uncovered their psychosis. I mean, I think, and often young people often don't want to believe it, and often you'll see this, that they will cycle a few times before they come to the sort of, yeah, every time I smoke cannabis I get really sick, and I should probably not smoke cannabis because I don't want to come back into the hospital again. So I think those are some of the some of the issues that we need to we need to pay attention to. I don't know the answer to that question, whether it's the THC alone that causes the anxiety or the CBD alone. CBD is thought to help treat the anxiety. But again, there are lots of variabilities in this, and I think we need to better understand which one is actually causing it. Cannabis as a plant is known to be cause both anxiety and help treat anxiety. So it's an interesting thing for us to think about.